the reason I'm not recording you, I'm recording me and the board. And the reason I do that is because since I started doing this thing where we kind of teach in adult 3, Miss Boyd's like, that's fine, but everybody's got to have access to it. So create the video and I upload to the Nurse Sensei website. It's there. If you want to look at it, you can. If other students want to look at it from whatever county, Washington County, Benton County, doesn't matter. In my clinical group, not in my clinical group, doesn't matter. They can all, you've got access to the website, you've got access to the video, right? So think back to electrolytes for a minute, because you've seen, is there an extra one of those? You've seen something like this before in class, right? Even before Miss Ramirez walked you through strips, right? You saw this. When did you see these things?
Torsades.
Well, we talked about torsades, yes.
Well, I'm just saying from your class.
Yes, that was, yeah, because we talked about torsades and we talked about ventricular tachycardia. We talk about those rhythms that are DRT, dead right there. So all of your patients have stuff. They're not DRT, correct? Okay. So if you think back to potassium, what did I show you related to the EKG with potassium? We talked about peak T waves when potassium's high. But if you recall, to introduce the notion of peak T waves, I had to show you what a T wave was, right? And in order to understand what a T wave was, you needed to understand what a QRS was. In order to understand QRS, you need to understand P wave, right? So we put those things up on the board. So now you have in front of you a pair of calipers, and you have a real live, real human EKG strip, okay? Now, if you recall, reason we cared about that is electrolytes impact the synchrony between the atria and the ventricle, right? And we recognize that with an EKG, right? Why do we put people on monitors? Because we want to monitor their heart, because for whatever reason, they're just a little bit sicker than someone who doesn't need a monitor, or their electrolytes are a little bit off, or we don't know yet, like ER, right? Walk in the ER, what do? They walk in the ER, put them in a bed, put electrodes on, right? Because we want to see what this looks like, okay? So for what is our normal human, as a human being, as a walking mammal, what is our normal rhythm? Right, normal sinus rhythm. And so there's sinus rhythm, it can be tachycardia, and then there's sinus arrhythmia. But for normal sinus rhythm, what makes the criteria of normal sinus rhythm? Heart rate is 60 to 100. Okay, that's part of it. 60 to 100. Okay, what else is part of that criteria? Okay, they have to have a P wave. Okay, and when we talk about the QRS, what about the QRS? Huh?
Narrow?
Yes, it has to be narrow, or there is a normal width. What is that normal width? Less than 0.12, right? Okay. Now, when we talk about P waves, what about P waves? One P wave for every QRS, right? There's a one-to-one relationship there. That defines normal sinus rhythm. And there's also, so there's the PQRS, but there's also this, right? The PR interval, which, what does that tell you? Right, it tells you the time it takes for the P wave to communicate to the ventricles. In other words, is this relationship communicating in a normal way? So, Neil, did you hear what I said? Okay, that's a normal response. Okay, Neil's ignoring me, and I say, Neil, did you hear what I said? Right? That's called a long PR interval. Right? Now, if he doesn't communicate at all, then we're talking about things like complete heart block, right? So we're not going to get into all the rhythms, But what I want you to start doing as we work through the semester is I'm going to be giving you these calipers throughout the semester, right? You'll give them back to me at the end of the day. And you'll be plotting out your strips, but I want you to see the components and look at on a piece of paper how we do that and make it meaningful. So for normal sinus rhythm, we have heart rate of 60 to 100, which is normal. There's a P wave for a QRS. That is a correct communication in amount of time. And the QRS is less than 0.12. In other words, the time it takes that impulse to move through the ventricles is relatively rapid. It's not delayed. So let me see something here. All right. What strips did you guys? Okay. All right. And then the last thing is there's also a T wave. Okay. So you have your calipers. So the first thing we do is we identify the QRS complex on your strip, right? The reason that's first is because it's biggest and easiest. Okay. So the reason we use calipers is, yes, we can do a 6-second strip, correct? But it is more accurate to use calipers. It's most accurate actually to use the machine, but we're going to do it with calipers. So what you're going to do is spread your calipers so that you can go from one QRS to the next one. And if you have a place on your strip where it's irregular, I know one of them has a pause in it. So you want to go to the place where you can put one caliper on one QRS and the next caliper on the next one. And if you're using a 12-lead EKG, use the strips at the bottom, because the strips at the very bottom, if you notice, they go all the way across the paper. You see that? And these are broken up. So you use these guys. But what we're going to do, right? Yes, Charlie. Okay. All right. So then, I'm going to teach you something. This is in your book. You don't have to memorize this. You will not have to memorize this for the test. This is basically building an understanding of how EKGs work. Okay? So you notice you have a big box. If you critique the art, you fail. Okay, just FYI. If you're like you're not symmetrical, you're coming back next summer. Okay. All right. Or next fall, maybe spring. Okay. So you notice you have boxes that look like this all over your paper, right? And the big ones are darker and heavier than the little ones in between. Yes? Yes? Mm-hmm. So one big box is 0.20 seconds. And the reason it's 0.20 seconds is because the paper moves at a specific speed that makes that 0.20 seconds. This is the way EKGs are done since the guy who put, I'm blanking on his name, Einthoven. Since Einthoven put a wire on this arm and a wire on this arm and just put the bucket of water and recorded the first EKG. Okay? For real, that's how it happened. 1800s, you're certainly not going to need to know that for the boards. Okay? But it's called the sweep speed. And you'll see, if you look at a 12-lead EKG, it'll show you the sweep speed. I don't know if, I don't think the rhythm strip does. It used to. It's 0.25 meters per 25 millimeters per second. Okay. So this is 5 millimeters, right? So if you do, right, that is 5 boxes, which is 25 millimeters. That is on a piece of paper 1 second. Okay, that's the set sweep speed. Now, you have your caliper set with your QRS complex, correct? All right. So you're going to do something in just a second, but I'm going to give you some numbers first. So if you have one caliper here, And then you place the next, you're going to have to just trust me on this one because it's in your book, you can validate it, but it is the fact based on switch speed. So this is caliper number 1. If caliper number 2 is right there, then the heart rate is going to be 300 beats a minute. Okay, which is very fast. I've seen it, but it's very fast. All right? So it goes like this: 300, 150, 100, 75, 60, 50, 40, and then it continues on. So now you can take your calipers that you've used to do R to R on your paper, and you put them on this so that they land like so, and count the number of big boxes between your calipers. Mine, for example, is 3. So my calipers reach from here. 1, 2, 3. My calipers reach from there to there. Okay. Now you may have some slight variation. It may not land exactly on a big box, but you're going to get in a ballpark there. And there's ways you can do the smaller stuff, but I don't want to get that super granular. Okay? Because then we're getting way too granular. What I want you to see is how we do this with calipers to calculate our rate. I've done an R to R, and I have a rate that's 100. So could this be normal sinus rhythm? Yes, it is like right on the bubble, right? You're pushing it, bro. 101 in your tachycardia. Right? Okay. So it could be normal sinus rhythm. Now the other thing for it to be normal sinus rhythm is it has to be regular. Okay? So take your calipers now that are on a couple of QRSs and check your other, without adjusting your calipers, check your other R to R's. Do you have to move your calipers, or are they the same as you go across your EKG paper? Yours are regular, Alex, regular, irregular. Yeah. So just yours, regular, Charlotte.
No.
Okay.
Mine is regular. Mine is
That's,
a
we don't know that yet. I should have cut that off your paper. You don't know that yet. But it is, so I just asked you if your R to R is regular or irregular.
it's irregular.
It's irregular, okay. Regular? Regular, okay. So we've got a lot of regulars. What rates do you have?
At 75.
75,
80.
80, 52,
74.
74.
What was it?
Yours is rate. Yours is kind of all over the place.
118.
118. So we've got a 118. We've got some in this range. We've got 50. Is it 54, Neil? Okay. Yep. Savannah, what was your rate?
I got 100.
100. Okay. So it's 100. We got 2 at 100. Brenda. Never mind. 82.
Yeah.
Okay. So you're a little over 100.
Yeah.
Okay. All right. So we've got another one that's over 100. All right. So these are, Charlie's, yours was 118?
Mm-hmm.
Okay. And this one's irregular. Who else was irregular? What was your rate?
103.
103. Okay. So we have several strips that could be normal sinus rhythm. Agree? Because they're meeting our initial criteria. The heart rate's 60 to 100, and they're regular. Can this be normal sinus rhythm? Nope. Can this be normal sinus rhythm? Can this be normal sinus rhythm? Can this be normal sinus rhythm? 54. Can it be normal sinus rhythm?
Regular?
Below 60,
Oh, shoot. Yeah.
right?
Yeah.
So it could be normal for this patient, right, for their resting heart rate, but it's not normal sinus rhythm, right? So you got to think like a cardiologist here for a little bit. So it could be normal for them, but it's not normal sinus rhythm. They could have a P wave for every QRS, regular, okay? They get a P wave for every QRS. QRS can be normal, their PR interval can be normal, they got a T wave. It's just not normal sinus rhythm. What is it? Sinus bradycardia, right? It comes from the sinus node and it's lower than 60, right? But we have these two others. We don't know what they are because they're irregular. We haven't done the rest of the stuff yet, right? So you can see how you can use calipers and start diagnosing, right? You can start weeding some things out. Can this be normal sinus rhythm even if it's regular? What would this be? Sinus tach. The same for 118 if it were regular. See how this works? Okay, so now we're going to do the next thing. We're going to see if we have a P wave for every QRS, right? And this is pretty easy to just look at and see on your EKG strip. You're going to look for, so you know where your QRS is. The first little bump in what we call the isoelectric line is the P wave, okay? So when we're looking at an EKG, this first thing right before the QRS is the P wave. So you got a P for every QRS, okay? Kara? Okay. Savannah, P for every QRS? No? Brenda? Okay? Okay. Oh, I should have put your numbers like with your name so we know. Because your rate was what, 80 something?
82.
82. So we got 82, which is in this possibility, but we don't have a P wave with every QRS. And what was your rate, Brenda?
111.
111? Oh, that's right. So we know this is not, but you said yours was regular, correct?
Mm-hmm.
Okay. So hers was regular, so it could be sinus tachycardia, correct? However, there's not a P for every QRS. So can that be sinus tachycardia? No. Okay. There's something else on there. All right. Or we're not just not saying P waves. Okay.
I think that's the topic, 'cause it's really small.
And it could be, right? So that's the other piece of it.
It's really, really funny.
Look at lead two closely.
Yeah.
Okay. All right. So now we change, and yours was what? Your rate was what?
My rate was 111.
111. So this one is regular, and yes, there is a P for every QRS. So it could be sinus tachycardia. You have a P for every QRS?
No.
No?
Yes.
Okay. So the 54 has yes.
74 is mine and my yes.
Yes. All right. So now we have a P wave for every QRS. So this could still be sinus bradycardia. This cannot, which was one of our options earlier. This one is too fast. So you can see how we're narrowing down what becomes normal sinus rhythm. And mine is 100 or a little bit over. So mine also cannot be normal sinus rhythm at this point. All right. Now we want to see, is the QRS normal? So that's, you take your calipers and you literally measure the width of the QRS. So the way you do that is where you may not have a Q wave, you may just have an RS like I've drawn here. You start there and you measure to where it returns to this, what we call the isoelectric line. You measure from there to there. And it should be less than or equal to 0.12.
If you have a Q wave, measure where
You include the Q wave. Do you need a pair? I've got more. All right, did you get measured? Yeah? 0.12 or less? Okay. Neil?
Yeah.
Brenda?
Yeah.
Savannah? Working on it?
Yeah.
I'll come back to you. Kara? Taylor? Okay. Charlie?
Yeah.
Okay. Anessa?
What about,
Are these inverted?
well, what you have is a small S wave and a big, a small R wave and a big S wave. That's what you have there. And are those less than 4.2? You measure all the way up to here.
And you know if it's less than 1.2? But
Okay, yes, and now put that like, one of your calipers right there on it. So that's 4 little boxes. See that? Okay, so, see the big dark line? Put one of your calipers on the dark line. And then count the box. Little box.
Okay, so y'all said you're less than 4.12. Less than 4.12? All right. Okay. So remember this box that y'all were thinking nasty thoughts about because it's not even? All right. So this is 0.20 seconds, correct? So if you divide 0.20 seconds by 5, what do you get? 0.0 what? 0.04. So one box is 0.04. Okay. So 2 boxes is 0.08. And 3 boxes 0.12. I mean, I appreciate you following the theme there, but we're adding, right? So we got to go up to, we got to add some tenths here when you get enough hundredths, okay? So 3 little boxes is 0.12 seconds. Make sense? So Anessa, what was yours? It was 4 boxes, right? Okay. So Anessa's was 4, which is 0.16. So now we have at least one of these strips that has a wide QRS, right? So by criteria of the QRS being normal, can it be normal sinus rhythm? By basic criteria. No, it cannot. Now, the truth of the matter is there are exceptions to that rule, but we have to add a descriptor. It's not just plain normal sinus rhythm. It would be normal sinus rhythm with a bundle branch block. Okay? But we're not going there. Okay? Because I know that bundle branch blocks are not going to adjust. Okay? So what I'm trying to show you is, with our calipers, taking measurements off of EKGs, we can determine the rhythms we're identifying. So no, it's not normal sinus rhythm. So we're eliminating these others, and eventually we've got to figure out what they are. And there's criteria for that. Okay? And I'm circling back to why does this matter to a critical care nurse? Right? Okay, so now you've looked at your strips, and we've looked at all this criteria, and we've said that for most of us, the QRS is normal. So we've got some sinus tachycardia in there. We have some sinus rhythm. We have something that doesn't have P waves with every one of them, right? At least one, I think, right? Mm-hmm. Okay. So now we want to know if the PR interval is normal. And the PR interval is supposed to be what? Less than 0.20. Okay. Again, not memory work, but just, okay. So now take your calipers and you go from the beginning of the P wave to the beginning of the Q or R wave, you know what you have. And then you're going to take it to your little boxes and see how many little boxes you have.
Okay.
Or dots, I want to see.
Or, yeah, the little ones. The little ones.
We don't have to grade.
You don't have P waves, that's fine.
I don't know, I don't think I want to see.
Okay, you may not.
I don't think you do either.
Okay.
Okay, I don't think you do either. All right, so what was your PR interval? Less than 0.2?
Yeah.
Okay. Less than 0.2, Samantha? This is the one you've been working on. You see those black and put it like 3 foot. Yeah.
Oh.
Yeah, sensitive report. Okay. So we have one called flutter. Look right here. So turn it where you see. You see how between, so if you look right here, it looks like you have a P-wave right here, right? You come over here, it looks like you have a P-wave. And if you come here, it looks like you have 1, 2, 3. Actually, you have 1, 2, 3.
Oh, thank you.
You just hold on to that.
I love boxing.
So in other words, your PR interval is not this.
Okay.
Okay? 4 squares, so 0.16.
Yes.
So is it less than 0.20? Yes, it is. 0.12? Okay, so we have 3 people who don't have P waves with every QRS. All right, just fine. But the rest of you have PR interval that is less than 0.20. So now we have eliminated all of the blocks. Okay? Because if you remember, Ms. Rabidez told you first degree block is a PR interval greater than 0.20. So we've eliminated all the blocks, right? We've got some tachycardias. We've got some that don't have a P wave. Okay, so we can't measure this, but that takes them out of the normal sinus criteria. Now, do all of you have T waves? Okay, so everybody's got T waves. So if you have met this criteria, raise your hand if you've got a normal sinus rhythm strip. Right? So of all of us, but your rate was faster, wasn't it?
Yeah.
Okay, so do you have a normal sinus rhythm strip? Raise your hand if you got a normal sinus rhythm strip. Right? I don't because my rate's a little over 100. So out of all 9 of us, 4 of us have normal sinus rhythm. Right? So you see how the criteria starts mattering. All right. Now, if you have more than 1 P wave for every QRS, there's only 1 rhythm. Well, no, that's not true. There's a couple of blocks. There are a couple of the blocks, but only 1 rhythm that has more P waves than QRSs, and they're actually called flutter waves, and it's called atrial flutter. Okay, remember talking about atrial flutter with Ms. Ramirez, right? Okay, so if you put your calipers, Savannah, on 1 P wave and then go right to the other in the same spot, whether it's the beginning or on top, and then tell me how far apart those are. Yeah, for her, from P to P.
It's 1 box.
It's 1 box. So Savannah's P waves are this far apart. So what's her atrial rate? The atrial rate is 300 beats a minute. There's 1 rhythm that has an atrial rate of 300 beats a minute. It's atrial flutter. Okay? So the atria are beating like this in an organized fashion, but fast, very fast, and the ventricles are responding at a slower rate. So this is doing this, and the ventricles are responding at a lower rate. Okay? Whereas with sinus rhythm, you get it like that, right? In normal time. Now, to confirm, the last thing we do to confirm that we have a regular atrial rate is we take our calipers and go from P wave to P wave.
You've already done this, so you check that box. Right? Go to P wave, which, right, you can't, right? And then you see, is the P wave to P wave rate the same as your ventricular rate? This is mainly for the 4 of you that I know have P waves that we narrow down. So Alex is nodding her head. Neil's nodding her head. Kara, Taylor. All right. So now we have atrial regularity, ventricular regularity, and there's a P wave for every QRS. So do you have normal sinus rhythm? Yes, you do. We've already talked about what Savannah's got. Are your P waves regular? Brenda?
Yes.
Yes. And is it the same as the rate of your ventricles? Should be. Should be.
It's because they're really small.
Yes, they are. And it's not real large. So you take the calipers here from the beginning of the P wave. Like so.
Yeah.
Pressure on it.
That's not where you're at on it.
So there you go. And you will see your rate for that.
Okay.
Yeah. Right.
So.
So your atrial rate matches your ventricular rate, but it's over 100, correct?
Yes.
So have you met the criteria for sinus tachycardia? You have. Have you met the criteria for sinus bradycardia?
Yeah.
Okay, so we have sinus bradycardia, we have sinus tachycardia we discovered through this process. We have sinus rhythm, right? And we also discovered atrial fibrillation, or excuse me, atrial flutter. Okay, you see how the calipers help the process, right? Okay, now we have 2 weirdos in the group because they don't have discernible P waves. Okay, so was your rhythm regular?
No.
No, rhythm's irregular, right? And we're talking about, so they have, is your heart rate 60 to 100?
Every 118.
118,
103.
103. So it's above 100. You have no discernible P waves, correct? Okay. And is your ventricular rate regular?
Not like my QRS.
QRSs?
Yeah.
Is it?
I thought it was 2 box I measured, or 2 boxes.
It can't be off at all to be regular.
Huh?
So come down here, put your calipers on this first. Okay. Now walk that across your strip.
Oh, okay, like what I, okay,
Yeah.
never mind, yeah.
Yeah. So is your R to R regular?
No.
No. And in essence, it's not as well. Okay, so if your R to R is irregular, there are a few rhythms that can be. It could be sinus arrhythmia. Okay, that can be irregular. That can be a normal thing, but it's just sinus arrhythmia because it's not regular. Is it sinus?
No,
Because why?
because they're not the same.
There's no what?
A P wave.
There's no P wave, right? No discernible P wave. So it's not sinus arrhythmia. Okay, it could be a block, first degree, or excuse me, second degree or third degree. Those are irregular rhythms. Okay, but you have to have a P wave for those, correct? Yep. More PRPs than QRSs, but you got to have a P wave for a block. So do you have a block? Nope, because you've got no P waves, correct?
Yeah.
Okay. The other thing you could have is flutter waves. Atrial flutter sometimes can be irregular, right? But do you have flutter waves? No, you have no P waves that you can tell. In fact, you've got a scratchy baseline, right? So if you have an irregular rhythm and no discernible P waves, there's one condition that can be. And what is it? Atrial fibrillation, right? So you see how you use criteria to discern what rhythms you care about. So again, I started this conversation by saying
What's the difference when we put a monitor on someone? Why do we do that? Okay, to guide interventions, so we have an idea, because they're a little bit sicker than the other guy, right? We want to monitor their heart. So if you're in an area like progressive care or ER, PACU, whatever, where they put a monitor on someone, it is implied that you understand what you're looking at, what you're assessing. It's part of your assessment, right? So that's why I wanted you to bring one from your patient, because this is what you looked at today up on the monitor. You didn't know what to call it perhaps. Or maybe your nurse told you, oh, he's in AFib or he's in whatever, but they've had the training so that when they're looking at the monitors, they know the rhythms they're looking at, or at least they know that's a bad change, right? Like I've taught you the severe bad change, VTAC or asystole, right? So if you walk in the room or you walk by the room and you see a flat line, what's the first thing you do? You go in and check what? Huh? Yeah, you go in and check responsiveness. You may call a code, but if you walk in and they're just holding the leads in their hand, which I've had patients swinging them around like it's a top, or something, swinging their leads in their hand. Had one swinging an art line one time. That was fun. That little sundowners. I hadn't gotten in to do my evening assessment. 7:30, I walk in. I'm like, why is my art line offline? It's because he pulled it out and swinging it. Okay. So you check to see if the leads are on, because we're not going to go in and do compressions on someone who doesn't have leads on. Right? But if it's asystole, we want to know. So if they're laying there giving you the Q sign, say Q. You'll catch it later. So if they're laying there, not responding, oh, did you just not get it? Takes a minute. Anyway, all right. So if they're giving you the Q sign and they're completely unresponsive, should we just start doing the compressions? Yes. If the leads are on, they're unresponsive, we've got a system. So the point is, as critical care nurses, you have to be able to recognize these things. So one of the things I would do, because I'm 6'5" and I could see over the curtains, when I was working with newer nurses, I would go in and raise their monitors so that I could see them as I walked around the unit. When I'm going to take care of my patients, I could see their monitors from outside because it was above the curtains. And then they would come in later and go, why is my monitor up so high?
Please, security alert, BERT response from 427.
Okay.
Attention please, security alert, BERT response from 427.
She's in BERT
please,
response.
security alert, BERT response from 427.
More aggressive.
Okay. Look, you guys see an eraser anywhere? Do you not see an eraser? I don't see a Kleenex or anything either. Not going to use mine. Yeah. Oh, maybe I could use Neil's thing. Neil's tattoo. That's his tattoo cover. It's not working very well. Okay. So I wanted to introduce you to this because all summer you're going to be looking at, wherever you are, you're going to be looking at monitors. So we're going to practice this from week to week to identify certain rhythms as we see them, as we come up. We've got one that Anessa picked up that I'm going to show you later. We're not going to get into that today because we involve more talking, and I want to cover some other things. So, Brenda, I would like for you to tell everybody about your patient.
Okay, so I'm a 62-year-old female who was complaining of shortness of breath, fatigue, and she had edema going on. So she got sent to the heart cath on June 21st, where they basically discovered she had CAD, and they referred her for a bypass surgery. So she had that done, and then she just declined from there. So she went into respiratory distress. Later on, when she was extubated, and she complained of like having pain and she couldn't cough or take deep breaths. They had to intubate her again. She got really bad. Her husband said that she had had bronchitis symptoms for 2 to 3 months prior to the surgery. She had a 40-pound weight gain. She was smoking up until the day of her surgery. So, yeah.
She was doing everything that,
Like,
okay, all the things that we tell you not to do before surgery, I'm going to do them
The
all.
morning of surgery too.
Yeah. Okay. So we split this lady's chest open and we do surgery on her heart. In the process of doing surgery on the heart, when the physician turns over to perhaps see if he needs to do a bypass on one of the posterior vessels, his thumb goes into the right ventricle. Makes a hole. When I say goes into, I mean goes into, right? So poked a hole in, and he had to re-suture that. So that's a major adverse event as a result of surgery. All right. So when we did adult 1, we started talking about, when we're talking about one of the first things we talked about in class is we talked about fluid management, correct? And in talking about fluid management, before we ever talked about giving fluids, we talked about how your body manages fluids itself, right? And how is it that the body does that? What's that called? Well, RAS system is part of it, right? But I'm looking for a broader term that I introduced that has to do with the way your heart moves fluid through your body. Fluid, that is blood, through your body. I've given you a hint. I said, yes, it is the vascular system. I said heart, which implies cardiac, right? And if the heart is moving fluid, that is cardiac output, right? Okay, so that's cardiac output. And that then generates a pressure, correct? All right? And that there are a couple things that determine that pressure. There are actually 3 things that determine that pressure, right? If you think about it long enough. What's one of them? So volume, yes. How much volume? Specifically stroke volume with each stroke. So volume, yes.
Preload?
Okay, volume is preload.
Okay.
Okay, so you're thinking along the same thing. So there's resistance. How tight are the pipes? Correct? Because a couple of you had septic patients. Are the pipes tight? Were your pipes tight today? I thought I was going to pass out 3 times. Was your patient's pipes tight? No, because we had to do what? We not just fluid. We gave her something else. We talked about it specifically, and you looked it up.
Oh, yeah.
Norepinephrine. So she did not have resistance. We had to create resistance to get a good cardiac output. Correct? All right. So we have to have volume, we have to have resistance, and we have to have something else. Well, afterload is volume. What'd you say? Contractility. Okay? Right? You remember these things? Yes? Okay. So in adult 1, when you're assessing a patient in adult 1, you didn't have any numbers other than blood pressure. Correct? 120/80. So when you're assessing patients, whether you're with me at the VA or whether you were at Springdale or wherever you were, Mercy, wherever, for your adult 1 clinicals, how did you assess volume on the patients you cared for? Okay, edema, crackles, what else? That would tell you about too much volume. Say it louder. Cap refill. Mucous membranes, because it could be dry if they're dehydrated. We talked about hand veins, right? When your hand veins are distended or not. If somebody's standing up and their hand veins are at their side and they're flat, volume is low, right? Because your hand veins should distend when they're at your side, at least a little bit. Okay, so no numbers involved, but the distended hand veins reflect a pressure in your veins, correct? So you're assessing a volume status and a pressure or a resistance there. The same with cap refill, because it should be filling fast enough. This cap refill also tells you something about contractility. Yes, because if you've got good cap refill, you blanch and it immediately fills back up, you've got good contractility, right? So these are coarse measurements of cardiac output. There were other things we talked about. If you remember, I connected it to everything we do to assess. Mentation, urine output, all of those things, right? Now what Ms. Rogers has introduced is something more specific. Because this cardiovascular system is a closed system. What do I mean by that? Okay, it recirculates. Is your car's motor a closed system? Is it? Does exhaust come out of your engine? Yes, and you have to have air flowing in. So it's not a closed system. It's a combustion. Basically, we're propelling the car with explosions, right? So we have to have something coming in. We've got fuel in there, create an explosion. Something goes out because we have to propel, right? So there's generation of motion and all the pistons and all that good stuff. So, but the cardiovascular system, do you have something, like right now, do you have something going into your cardiovascular system? Well, like a fluid or something. So we're not putting any fluid into our cardiovascular system right now to keep us moving, correct? And do we have anything coming out of our cardiovascular system? Hopefully not. What do we call that if it does? Bleeding, right? So it's a closed system. And when you have a pump and a closed system, what do you create? An infinite loop, but in all of those tubes, right? And so heart's here, closed system, and his pump is squeezing. So it creates pressure, right? Right? So a closed system is going to generate pressure. Right? So in this system we have, that is the cardiovascular system, that has the inferior and superior vena cava. This is pulmonary artery here. Again, do not critique the artwork. And coming off the left ventricle over here, we've got the aorta, right? So in this closed system, we have pressures everywhere, correct? All right. So before I go too much further, when you were doing this in adult 1, cap refill, urine output, all of that, we said you were assessing cardiac output, right? You're assessing organ perfusion. What you were not looking at were pressures within the system, but you're looking at the effective cardiac output, okay? You were looking at hemodynamics. You just didn't have numbers for a hemodynamic in this spot, okay? So what Brenda's patient had was she had a patient with a Swan-Ganz catheter who had pressures relative to each chamber, okay? So did you get some written down? Okay, so what did you get for the pulmonary artery pressures?
38, yeah, it's 38-22.
38 over 22?
Yeah.
Did you have a mean arterial pressure?
29.
29? Okay, seems about right. All right. Okay. So you have a pulmonary artery pressure. What other pressures did you have? Do you have for me?
CVP.
Okay. So CVP, central venous pressure. Okay. Where is central venous pressure? Huh?
I don't wanna be wrong.
What is the most central vein? Anybody wants to guess? The most central vein.
Vena cava.
Right, right. It is the largest and most central, either the superior or inferior vena cava, depending on where you're measuring it. Okay. If we had a catheter in her groin up to her heart, it would be the inferior vena cava. Right? If it is like a Swan-Ganz catheter, the opening where the CVP is measured is right here. Okay? So let me transpose a Swan-Ganz catheter onto this picture for you. So it goes into the neck or femoral, but it comes, we're going to go from the inferior to superior vena cava. So it goes here into the right atrium. Right? So this is the right atrium. Then it goes down into the right ventricle, into the pulmonary artery to measure pulmonary artery pressures right at the tip of the catheter. Okay? So that big yellow catheter you all saw pictures of in your book, that's exactly what it's doing. Now there's an opening right here that measures the pressure in the right atrium. And it'll also be commonly, there's another opening right up here that allows us to measure what is called the CVP. What was your CVP?
24.
24. So does this tube right here have a pressure in it? It's not a trick question. Yes, it's a closed system, correct? Is it going to have a pressure? Yes. It's a venous pressure, so is it going to be high or low? It's going to be low. Because what's the high pressure side? The arteries. Arteries are high pressure side, right? Because systolic blood pressure is 120 over 80. Correct? Okay. So low pressure side over here. So I'm going to take this 24 and put it right here. Okay? All right. Now, so we have a pressure here, which, did you have an RA pressure? Okay. It's probably the same, 24, maybe 25.
I had one, so I also wrote down the ones that she had as soon as I put it in
Uh-huh.
the podcast, and it was, her RA was 39.
Okay. So she was probably a little fluid overloaded.
Yeah, but they didn't do one.
So we want to stay consistent with the numbers you saw today for the exercise we're doing here. We don't measure a pressure in the right ventricle, right? Because what we care about with the ventricles, what's the real thing we care about with the ventricles as far as pressure in the heart and that sort of thing? Well, yes, because contractility has to overcome resistance. So for the right ventricle, what is the blood pressure for the right ventricle? It's the pulmonary artery pressure, right? Because the ventricle is pushing into the pulmonary artery, correct? What does the left ventricle push into? Not a trick question. The aorta. And in the aorta, we have a pressure of 120 over 80, right? Because everybody's normal. So, Brenda, what was your patient's blood pressure?
So the last one I got was 104 over 69.
104, was that off the art line?
Yeah.
Okay. 104 over 69. And this is directly measured from the radial artery. Okay, so as close as we can get to the aorta without being like really invasive. Okay, so 140 over 69, do you have a mean?
76.
76. Okay, so this is our mean arterial pressure, right? 76. All right. So you can see now that we are generating pressures in the pulmonary capillaries, or pulmonary artery. Do we have pressure in pulmonary capillaries? Yes, right? Because they're just very, very small arteries, right? Now, here's the part that blows everybody's mind with a Swan-Ganz catheter. Is when we talk about either what is referred to as a pulmonary artery occlusive pressure or a pulmonary capillary wedge pressure. Tomato, tomato. Okay? It's the same thing. Okay? So when you see those acronyms, it's the same thing. Now, what I know is that Miss Rogers is not going to expect you to be able to recite the values for all of these things. But it's important, she does want you to know what they mean. Okay? Because resistance has to do with pressure, correct? Correct?
Yeah.
All right. So is the pulmonary artery pressure a pressure measurement? Yes. Okay. So the answer is in the name. Okay. All right. Is systolic blood pressure a pressure measurement? Yes. Okay. So those two things have to do with resistance. Agree? All right. Now, we have other things that tell us about volume. And volume is measured in low pressure chambers. And it's usually a single digit. Okay. Do we have a volume measurement on the board? That one you got to kind of think about it. The answer is yes. Anybody want to guess which one it is? No. Well, it will be, but it's not on the board. So
The one measuring at the superior,
this one right here?
yeah.
Yes, the central venous pressure is a volume measurement. Because so the right atrium, does it have a lot of muscle in it? No. Is it a closed chamber? No. There's not a valve up here. It's just an opening, right? Same with inferior vena cava. There's not a valve there. Is there a tricuspid valve? Yes, but it's between the atria and the ventricle. Okay? So this is a very low pressure chamber. So central venous pressure is a pressure, but is a volume. It's a pressure from the volume that's in that chamber or in those veins. Does this make sense? Kind of pulling some of the things together. So they tell you about volume, how much volume is coming into the system. Specifically now, volume coming into the right side, right? Do we have a volume coming into the left side? Really? Huh? Do we have a volume coming into the left side? Of course we do, because the right side's pushing it forward, right? Makes sense, right? So if we have a Swan-Ganz catheter that's on the right side in the pulmonary artery, it's hard then to measure the volume in either the left atrium or the end of diastole in the left ventricle. Okay? And that's what we really care about, is what is the volume here before the heart tries to refill. That's preload, right? Before the heart starts trying to refill. So as I said before, this is the part where everybody's mind just blows and brain cells start oozing out of your ears. So I'm going to draw it this way on the board. Here's your Swan-Ganz catheter. Okay? And your Swan-Ganz catheter is in the superior vena cava. Right? And then it is in, what's next? Right atrium. Right? Right ventricle. Then pulmonary artery. All right, and then we have the tip here that's measuring pressure, right? And this is measuring pressure based on holes in the catheter, measuring pressures in those areas. Does this make sense? Okay, so over here on this side, this is the left side now, What's next? I'll give you the first one. Pulmonary vein, correct? Okay. And then you've got left atrium and left ventricle. Now, the left ventricle is going to create a systolic blood pressure, correct? Because then you're going to go to aorta. All right. We're not going to run this catheter all the way through so that we can get a preload measurement on the left side. We can't do that. Unsafe. Not possible. Okay. So what we do then, a couple of doctors by the name of Swan and Gans, legit docs, for real thing, deduced that we could put a balloon right here. And if we inflate this balloon so that it occludes a pulmonary capillary, right? Now, is this going to be measuring a pressure generated by the right ventricle? Still. Why? Because all of the pressure is blocked up here. Okay? So what you're going to have here is a passive measurement. I say it that way to emphasize that it's not a direct measurement, it's a passive measurement. Okay? It's a passive measurement that comes from here onto that little measuring device at the end of the catheter. Because all of these pressures are blocked off. Right? It's like this. If you've got a water hose, you got water shooting out the end of it, you've got a pulmonary artery pressure, correct? If you kink the hose back here, what pressure do you have in the hose on that end? Atmospheric pressure pushing on the inside of the water hose. Because whatever water's in there is going to run out. So you're not going to have any volume. All you're going to have is atmospheric pressure. Does that make sense? Because you got it kinked off. It's the same principle here. So this is the part where everybody goes, I don't get it. It's measuring the left side. It's because you blocked all the pressure. Okay? So now we have a volume measurement for the left side. Right? So we had pulmonary artery pressure, CVP. This is for the right side. Now we have pulmonary artery occlusive pressure, pulmonary capillary wedge pressure, whatever you want to call it, for the left side. Okay? Does this make sense? All right. So we have volume measurements for both sides, and we have pressure measurements from both sides. Okay? So the key in this, the takeaway, the part you need for like testing and that sort of thing, is thinking, what do these numbers tell you? Okay? So if you have a pulmonary occlusive pressure that is normal, 10, 8, okay? So no, it's normal. But your central venous pressure is 45. Where is the fluid? The fluid's on the right side. So if it's on the right side of the heart, what assessment finding are you going to have?
Pulmonary.
Not pulmonary, right? Because if the fluid's high here, where is the edema going to be?
They're lower.
Exactly, right? So that means we've got lots of fluid in the venous side. All right? Does this make sense? Yeah? Okay. Now, your central venous pressure is 12. 5. Pick a normal number. I don't care. Pick one. 5, 8, 12. Okay? But your pulmonary artery occlusive pressure is 25. Now, where's the fluid? Okay? It's in the left side, but where are you going to see it, find it, whatever, on your patient?
Okay.
In
That
the
makes
lungs.
sense now.
Right? Because if the volume is over, if the volume's over here, where's it going to back up to? lungs. Now, the truth is they could ultimately back up to their feet, yes. But to understand what the effect the pressures have here, right, you've got extra fluid on this side. Okay, now let's start pulling some things together. Okay, so if you have a pulmonary artery occlusive pressure of 35, you've got extra fluid here, correct? Okay, what effect is that going to have if somebody's had bypass surgery, has strain on their heart? What effect is that going to have on cardiac output? Don't think about your immediate first response. Think for a second. Think for a second. If you've got a heart that's had surgery, been worked on, maybe you had some heart issues, right? So because she needed some stents or whatever, right? And we put extra fluid in it, what's going to happen to cardiac output?
Are they wrong?
No.
Increase?
Okay, it may not necessarily increase. It may put too much workload on the heart because the fluid backs up in the lungs, and cardiac output may go down, right? Because there's too much fluid for the heart if it's not contracting well to push that volume forward. Does this make sense? Okay, so when you think about pulmonary artery occlusive pressure, if it's high, you think about increased workload on the heart, decrease in contractility, and backing up of fluid in the lungs. Congestive heart failure. Remember us talking about congestive heart failure? There it is. If you got somebody in bad congestive heart failure, you go poke a swan in them, you're going to have an elevated pulmonary artery occlusive pressure, and you're going to have a decreased cardiac output. Did you have a wedge on your patient? No, you didn't. You did not have a CVP, pulmonary capillary wedge. That would have been great if we had one. You can see where it comes in handy, right? Okay. So if somebody, all right, this is a great example. So your patient, did she have injury to her right ventricle? Yep. Okay, so doctor poked a hole, not intentionally, poked a hole in the right ventricle. So the right ventricle is weakened in its strength because it's had a hole poked in it. Comparing the right to the left, which is stronger normally? Left. It's got more muscle mass. It's got more work to do. So is her right ventricular contractility going to be increased or decreased? Decreased, right? Her contractility is going to be decreased because we poked the hole in it and we had to sew it back together, right? All right. Now, the right ventricle is not known for being able to contract very forcefully. So how are we going to, in her case, help improve cardiac output? Actually increasing volume. Okay? We put more volume into the system. If there's more volume passively in the system, then more volume is going to move forward, right? So she may actually need more volume. So like you see in a question something about someone having a right ventricular or inferior wall MI, heart attack. They have damage to the right ventricle. We don't want to dry them out because if this ventricle is weak in pushing blood forward, what's that going to do to stroke volume? Lower it, right? And what does stroke volume do with cardiac? How does stroke volume play into cardiac output? So cardiac output equals stroke volume what? Times heart rate, right? You have to have a decent heart rate and decent stroke volume to have a decent cardiac output. So if we have a weak right ventricle that's not able to push forward, we have to have more volume so it gets through the system. Make sense? Okay. Now, if we have a weak left ventricle, do we need more volume in the system? No, because if we put more volume in the system with a weak left ventricle, where's it going to go? Lungs, and you've got oxygenation problems, right? Make sense? So when we have a high pulmonary artery wedge pressure, what medications might we be giving them? Lasix, try to pull some of the volume off. There's another medicine we might give them. You ready to shine?
No,
Did you look it up?
yes.
Hear that enthusiasm?
I don't know how to pronounce it. Is it Milrinone?
Milrinone. Yes, Milrinone.
Close. So it treats acute heart failure and strengthens the heart's pumping action, relaxes the blood vessels to improve blood flow, while decreasing heart workload and reducing pulmonary infection.
Okay. So it said it helps the heart do what? One of the first things you said.
It strengthens the heart's pumping action.
Okay. Strengthens the heart's pumping action. So this drug Milrinone helps what part of preload after loading contractility? Helps the heart's pumping action, contractility. Okay. Now it does it two ways. Okay. It does two things to help improve that efficacy of contraction. One is it actually helps the muscle fiber squeeze harder. Okay. There are 3 drugs out there that do this. Ionacor, Primacor, which is Milrinone or Amrinone, okay, and dobutamine. If you look back at your piece of paper, I know there's got a piece of paper, it's got the blanks that you fill in. Somebody nodded their head earlier today that you've seen this, so don't act like you don't, right? You got some blanks that you fill in, it asks you like what receptors does something act on. Certain Dobutrex is on there, similar to Milrinone in its effect, helps the squeeze. I think Milrinone is on there. I'm not sure about Amrinone. Okay, I'm not sure about that one. This one maybe, it may not be. But the connection I'm trying to make for you is it's like Dobutrex. Okay, so coming back to questions, you have a patient with, blah, 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 patient had a heart attack, they've got a weak heart. Which of the following drugs might you suspect the provider's going to order? Lasix? So if it's a select all that apply. Lasix? Yeah. Norepinephrine? No. Weak heart, norepinephrine's going to make it pump harder against tighter pipes. Right? Right? Okay. So not norepinephrine, not phenylephrine. Milrinone or Dobutrex? Yes. So those are the pieces where you start thinking about hemodynamics and what are the drugs that she's talked to you about that might do what. Okay? So Milrinone is going to improve contractility. Now, aside from increasing the squeeze, what's another way to increase stroke volume? Decrease what? Not heart rate, workload or resistance. Okay? So a couple of you were talking about sepsis, right? So as they have a problem, they overdilate, so too little resistance. But when they have sepsis, their cardiac output skyrockets to try to keep those pipes filled because they're vasodilated. So Milrinone will cause the arteries to dilate a little bit, so that when your heart squeezes more efficiently, it's easier to push it out. Okay. Now, just to make a connection for you, how many of you have exercised in your lifetime? Not like it's a regular habit, have exercised. Come on. Come on. I'm not going to call you out, only if you don't answer, because all of you have exercised. All of you have experienced epinephrine. Yes? I mean, you've had babies, honey. You've had epinephrine in overdrive, right? So, I probably shouldn't have called you honey. So, anyway. All right. So, it's recorded and everything. All right. So, for posterity's sake. All right. So, we've all experienced the effects of epinephrine. What epinephrine does epinephrine increase your heart rate? Yes, it does. Does it increase the force of contraction? Yes, it does, because epinephrine beta 1, beta 2, right? So yes, it does beta 1. Increases heart rate, increases force of contraction. Does your blood pressure go to 180 over 100 when you exercise? Not if you're healthy, right? Perhaps if you have hypertension, does your blood pressure go up when you exercise? Yes, it does. It just doesn't go up to 190, 200. It goes up to, if you're healthy, 130, 140, perhaps 150. But what's happening, that's because your cardiac output is going up to meet oxygen demands. But what keeps it from going to 180, 190 is the fact that epinephrine also causes arterial dilation, right? So does it help you see how milrinone works here in this situation, right? So it is increasing contractility. So how do we know for her that it increased contractility? There are going to be a couple of numbers on there you haven't given me yet.
Yeah, there's a lot.
Cardiac output, right? And there's another one,
Cardiac index.
cardiac index. What was her cardiac output?
4.
4. And what was her index?
2.2.
2.2. All right. So she does not have a great cardiac index, but for what she's had done and a thumb poked in her heart, this is a reasonable cardiac index. Cardiac output is liters per minute. So as your heart squeezes, liters per minute, and you've seen those numbers somewhere between 4 to 8, correct? Right? A little bit different male to female, but 4 to 8. Cardiac index is what? In your book. 2.1, 2.1 or 2.2 to 4, some 4 point something, right? So what cardiac index is cardiac output divided by body surface area. Okay, so in case you haven't noticed, Charlie and I are slightly different in size. You may not have noticed that, but it's true. I've got a little more body surface area than she does. So for Charlie, a cardiac output of 4 may be fine, right? But a cardiac output for me of 4, I might feel pretty crappy because I've got more body surface area to distribute that 4 liters per minute over. Does that make sense? So, but that's why cardiac output is important to show us how that cardiac output is distributed in that person right there. Okay? Is this making sense? So those things tell us about the efficiency of the heart actually beating. And were we using any medications to support that? Which one? Milrinone. And different doctor, different set of circumstances, it could easily be dobutamine. Okay? Because those medicines are, you probably saw this word in your material, inotrope. Y'all seen that word in your book somewhere? Force. So those drugs increase the force of contraction. That's what a positive inotrope does. When you see that word, that's what it means, is it increases the force of contraction. As opposed to norepinephrine, which norepinephrine does what? Vasoconstricts by doing what, Kara?
The alpha 1.
Primarily alpha 1, but also affects beta as well. So the vasoconstriction comes from alpha 1 because that's in the periphery where vascular smooth muscle is. And it increases another hemodynamic component. So when we talk about norepinephrine, the norepinephrine increases what is called systemic vascular resistance. Okay? Have you had some systemic vascular resistance in your book? Did y'all talk about that in class? SVR? Has it come up in lecture? Not yet? Okay. So systemic vascular resistance is the real resistance measurement. That's what your heart's really experiencing as it's trying to push against the whole system. The systemic vascular resistance, right? Not just what's in the aorta, but what's in the system. So if you notice, I put some numbers on the board. So I want somebody to mathificate for me. So subtract 24 from 76. should be 52, right? Right? Okay. So that divided by 4,
Your answer can be 1,040.
okay, 1,040. This is her systemic vascular resistance. Did the book give you have, so y'all haven't seen this in the book? All right. So there's a range for this somewhere between 1,200 to 2,000. Okay. Could be a normal range. So for a lady who's had bypass surgery, has some tough time with her lungs, and had a thumb poked in her heart, is this an SVR we would like to have for her heart? Yeah. So Savannah, if your CrossFit coach said you're going to be doing 150,000 deadlifts today, do you want to do that with a bar or 135 pounds? Neither. All right. But if you had to do it with the bar, you'd like to do it with less resistance, right? So that you could conceivably get close. I mean, it's a lot of deadlifts. If you don't know, right? Even for CrossFit people, right? That's a lot of deadlifts. So the point to this is if you've got a muscle group or a heart, in this case, a heart that's challenged, you don't necessarily want an SVR that's 2,000. Okay? Right? So like your septic person, when we don't put swans in septic people anymore, but when she came back to the unit sicker than shit, right? And they're intubating her and doing all the things, her SVR was likely somewhere around 500. Okay? You see the difference here? So if you have an SVR of 500, what's the cardiac output going to be? High, low, or in the middle?
Low.
Why do you say low? Okay, so if you have an SVR of 500, that means the resistance is low, correct? Because this is the normal range. Yes? All right, so if the SVR is low, that means the vessels are vasodilated or vasoconstricted. You can answer this.
That is,
Vasodilated, exactly. Remember the picture that I drew for you for sepsis and something like that, right? So if you're vasodilated, how are you going to maintain perfusion? Well, yes, you constrict them. How's the body going to maintain before you do that? Increase heart rate, which is a way of increasing what? Cardiac output. Okay. So if you have an SVR that's low like this, cardiac output's going to go up. We talked about this when we talked about dehydration. When you get dehydrated and you don't have volume in there, your heart has to pump more heart rate and stroke volume to increase cardiac output so you don't die. Right? So the opposite is true as well. If the heart is weak, if we increase her resistance, so if we gave her norepinephrine, what would that do to her? Overwork. Exactly. It's going to make her heart overwork. And can anybody guess what would happen to her cardiac index? It would go down, right? Because the heart's having to overwork. We got a weak heart pumping against tight vessels, right? So I don't want you necessarily to remember all of these scenarios. What I want to get you thinking about is the strength of the muscle pushing against resistance with the volume in the container. And how do your medicines affect the volume in the container? Okay?
so you wouldn't want to give a pressor? You wouldn't want to give her a pressor?
Right. So she had a pressor for a time, but at this point, the pressor wasn't serving her anymore. So she's on Milrinone now, which makes the vessel softer and helps the heart squeeze harder to improve cardiac output. Okay? Now, Kara's patient needed norepinephrine because her pressure was so low, she was unstable on the floor, she was in septic shock, So they put norepinephrine on to tighten up everything, so her heart's not having to work so hard to beat 150 times a minute because she doesn't have enough volume in those tubes, right? So Neil had a different approach with hemodynamics. In his case, it's more preemptive. We're not dealing with either cardiogenic, which basically is what she's kissing up to, right? Because some people will define cardiogenic shock as 2.2 or lower. Depends on the doctor you talk to. So her patient's not facing cardiogenic shock. His patient's not facing septic shock, right? So she's not in a shock state. So we did something preemptively to help maintain enough volume to maintain a good cardiac output. What did we do? We gave her something. We talked about this right at the very beginning. We gave her that albumin. Because why did we give her albumin? All right, it holds the pressure because we did what? We pulled fluid off her belly. When you pull that fluid off the belly, if you don't do anything, what's going to happen? It'll go right back. And when it goes right back, then she becomes what? Hypovolemic, right? Because she pulls volume into this space out of her vessels. Unless we give her albumin, because the albumin is going to help her hold that in the vascular space. And they went, after they gave the albumin, then they gave what? Didn't you give Lasix after the albumin?
Yeah.
Right. So what that does is it pulls the fluid into the space, right? Then we can pee off the extra fluid, which will concentrate the vascular space, which will help her pull fluid into the vascular space and try to keep it off the belly, right? So it's also hemodynamic measurement, but in that case, it's all volume hemodynamics as opposed to pressure hemodynamics. Okay, this makes sense? Yeah. So this is how the numbers kind of fit together. I wanted to do this just to show you there are sometimes that these things we talk about that we're measuring with the Swan-Ganz catheter, we can also calculate. Right? In fact, the old-fashioned way, the apparently old-fashioned way to do cardiac output was to calculate it, right? So, so this is a little bit of something about your Swan-Ganz catheter, and the book talks about thermal dilution. Yes, injecting fluid into the Swan-Ganz catheter. Did y'all talk about that in class? No, in the book. Okay. So what thermal dilution is you're diluting the temperature of the blood in the right ventricle. That's what you're doing. You're diluting to change the temperature.
We actually did talk about that.
We did.
Oh, okay. So it is in there. All right. So out here, that in the part of the catheter that's outside of the body, there's a thermistor that measures the temperature. And I'm going to call that T1, temp 1. And then down here at the tip of the catheter, there is another temperature probe that I'm going to call T2. Okay? Because what happens is, you didn't see this setup because they don't use it. The machine does it all. So you probably saw it in the diagram in your book. There's a contraption that has a syringe. This syringe is a specific volume. It's a very specific volume. It's the most exact 10 mil syringe we have. And the catheter is calibrated to room temperature fluid and that much fluid, right? So it takes that out as a variable. So what you do is you go to the monitor, you push a button that says inject now, and you literally, it's a two-handed thing. You hold hard half of the syringe here and the plunger in this hand, and you just push it as hard as you absolutely can. Because if you push it slowly, then it's just seeping out the catheter and you're not going to get a good cardiac output measurement. Because what you want to do is you want to drop a bolus of 10 mils into the right ventricle. Because the right ventricle is going to tell you about what? Contractility, right? It's going to tell you how well it squeezes. And the way you're going to know how well it squeezes is how fast it goes from the right ventricle past this tip. Is faster better? Yes, because that means you're getting a better squeeze from your right ventricle. So so think about this for a second with Brenda's patient. Might this be abnormally low for Brenda's patient if we were doing it purely that way? Why does that make sense clinically? Exactly. We put a thumb in the right ventricle. So that could shift a little bit. If we're doing thermal dilution, that could shift the accuracy of cardiac output. You see that? See how that makes sense in this case? The same would be true of a potentially a right inferior wall myocardial infarction heart attack. Because it's essentially the same thing. We've damaged the right side of the heart, is what we've done there. So that's how a thermal dilution swan works. One thing I like to share, I used to have my first group in clinicals actually do this, and that is calculate a thick cardiac output. So I don't want to get too granular because Ms. Rogers is not going to ask you about a Fick. But a physiologist by the name of Fick, years ago in the 1800s, is like, I think we could calculate how much the heart puts out. This is where we started figuring out how to measure cardiac output index. And it's the concept that sits behind this. But he said, what if we measured something that changes before the right ventricle and something that changes after the right ventricle? Can you think of anything that's different between the right atria and the pulmonary artery? Something that changes in there. Well, yes, pressure, but it's something more simple than that. Close. CO2, right? So both oxygen and CO2 change in that window of time where it passes from the pulmonary artery or the right ventricle into the pulmonary arterial side and capillary side, because it passes the alveolus, right? So there's a thing called resting O2 consumption, which is how much oxygen your body consumes at rest. So if we look at O2 before it goes to the lungs, right, it's going to be low. So the amount we have to replace is going to tell us about cardiac output. So we can do that with the right catheter. You have to have a swan to do it. With the right catheter, you can measure PO2 here, and do the Fick equation and get a cardiac output cardiac index. That's the logic that sits behind this. Okay, and you won't have to know that on the test. So the question you want to know is, what do I need to consume when it comes to hemodynamics, right? You want to think about what hemodynamics or how hemodynamics are going to affect your assessment. Okay. So if you have a patient who has a high resistance, okay, what numbers would you expect to be high? Blood pressure, possibly the pulmonary artery pressure and the pulmonary occlusive pressure. Okay. Think about this for a second. We talked about a condition in adult 1 called pulmonary fibrosis. Correct? What effect does pulmonary fibrosis have on the lung tissue? Hardens it, makes it stiff. So if the lung tissue is stiff, then the lung vessels are also stiff, correct? So the pressure on which side is going to be high? The right, as Taylor would say, pressure. Because why? Because the right ventricle is pushing into those stiff lungs. Where's the left ventricle pushing? Into the system. So they may not have hypertension, so they might not have vascular problems. They've just got pulmonary fibrosis. So you've got a right ventricle pushing into pressures on the lungs. Okay. You remember us talking about COPD, COPD and obstructive, specifically now, is obstructive sleep apnea. What is a common result of obstructive sleep apnea? What kind of hypertension? Pulmonary hypertension. Why? So think about this with hemodynamics, right? It's the same principle. It's applying these things. Why would you develop pulmonary hypertension with obstructive sleep apnea?
When they lay flat, they have too much pressure on their lungs.
Exactly. So when you lay flat and you have obstructive sleep apnea, airways occluded, the interthoracic pressure goes up. If interthoracic pressure goes up, does the heart still have to push blood against a higher pressure, which causes the evolution of pulmonary hypertension? Right? Okay. So you could see where lung condition could cause right ventricular problems and cause pressure problems. Right? Can you see where if somebody had an inferior wall right ventricular myocardial infarction, where would the fluid be? Is it going to be in their lungs? No, because it can't get there. That's the hemodynamics. So the pressures on the right side will be high. Pressure, edema in the feet, yes. Right? But pressures on the left side, maybe not so high. Okay? So someone has a left ventricular myocardial infarction, or as we say, BAMI, for big ass MI. Okay, just in case you kind of drifted off to sleep. They have a big left ventricular MI. Okay, now, are the pressures going to be necessarily high going into the lungs? Not necessarily. I haven't given you anything to tell you there's something wrong with the lungs, correct? Now, they may ultimately get high, but we're talking about in the initial stages, kind of like your lady, right? So, where is the fluid going to be as a result of this myocardial infarction? Okay, in the lungs. Why in the lungs? Because it can't push into the aorta. It can't push against the systemic vascular resistance of what is normal, right? It can't push against normal because it's been injured. And that fluid then is not going to be able to get out to the system. So where is it going to go? To the left atrium and the pulmonary artery. And the symptoms you're going to see are pulmonary congestion, crackles, right? Now, ultimately, it may back up if it's severe enough and prolonged enough without treatment, yes. But that left ventricular myocardial infarction is going to show up with different hemodynamic measurements, right? Low pressure because it can't get out, and high pulmonary artery wedge pressures or occlusive pressures because it's backing up. Okay, does this help?
Yeah. Yeah, absolutely.
Okay, so one thing I want to add to this is we talked about contractility assessment, and this is something you should be thinking about. I've already hit a couple of you with it today, but there was a contractility assessment that we did that was not cardiac output and index, but you know of it because I brought it up to you. Don't answer. Okay.
Assessment?
It's a part of the assessment, usually has to be done by somebody for you, but it's an assessment thing we do.
Or is it the deep 10? What is it?
Good guess, though. You can tell them you're not remembering. How'd you look it up on your patient who had acute on chronic? Ejection fraction, your echocardiogram, right? So you have to think about echoes in your hemodynamics, in your cardiac and your contractility assessments, because your echoes, now they're not precise, they're not liters per minute over body surface area, but echoes tell you how efficiently that heart is squeezing as far as us watching it move. So it tells us about contractility. Is it more specific than cap refill and mentation and urine output? Yeah, because we can put a number of 30% on that, right? Or 40%. So it gives us a more specific idea, or normal, like your guys was what, 55, 60, even though he has a history of heart failure in the past, right? Okay. Good? Yeah. Okay. Stop the recording here.